Hi, I'm Dr. Sheila Reyes from the Philippines, reporting virtually for Room Now at the ACR 2022. Topics about hydroxychloroquine always show up in these meetings because it is an important drug for lupus and patients are maintained on it for long periods. Today, I'm going to talk about two abstracts that address issues on therapeutic thresholds and cumulative doses that I found interesting. The first one is Abstract 0982 by the group of Dr. Hackes, which was a prospective cohort study of 286 lupus patients followed for a minimum of 10 years. They looked into the average dose of hydroxychloroquine per year of disease duration, which was computed by dividing the cumulative dose of hydroxychloroquine from the time of diagnosis up to the last known follow up over the lupus disease duration. And they used the SLIC ACR damage index or the SDI to assess disease damage and recorded incidence of major adverse cardiovascular events or MACE. And the results of this study showed a statistically significant negative correlation between hydroxychloroquine per year dose and the SDI. So patients with an SDI of 0 had a higher mean hydroxychloroquine per year dose versus those with an SDI of more than 1. And this was consistently seen at all time points of the study. Now, in addition, patients who had developed major adverse cardiovascular events had lower mean HCQ per year doses than those who did not have or did not develop major adverse cardiovascular events. So this means that patients on higher doses of hydroxychloroquine had lesser damage accrual and incidence of MACE. Now, the second abstract with number 0344 presented by Dr. Garge looked into two things: how factors such as renal function, dose, or social determinants can predict changes in hydroxychloroquine blood levels. And number two, clarify hydroxychloroquine thresholds that can predict adherence, efficacy, and and patients at risk for toxicity. So patients on hydroxychloroquine for more than a month had blood levels measured using liquid chromatography mass spectrometry. They used also sorry, mixed regression models to assess how renal function, social determinants, and other factors would predict change in hydroxychloroquine. And they saw that, just to mention, they mentioned that clinically significant change in hydroxychloroquine levels, as previously seen in other findings, was defined as a more than or equal to 8% change in mean hydroxychloroquine levels. So their findings show that for patients on CKD stage 2 or more, or through using the GFR, it was associated with a clinically significant increase in hydroxychloroquine levels. And in terms of the threshold levels, they found that hydroxychloroquine at a dose of more than 500 nanograms per ml detected adherence. A dose of hydroxychloroquine between 750 to 1,000 nanograms per ml was effective to prevent flares, and that supratherapeutic levels, such as that of more than 1,500, were seen in CKD patients. So these results reinforce one of the many beneficial effects of hydroxychloroquine and underscores how it remains to be a major therapeutic drug in lupus. We see in these two abstracts how this drug, if dosed appropriately, confers better outcomes for our patients. In my area, blood hydroxychloroquine levels are not routinely done because it is not readily available and costly. So will these findings change how we give hydroxychloroquine to our patients? Probably not yet, but most likely in the near future as evidence supporting these data continue to grow. Follow me on Twitter at Rumarampa and tune in to Room Now for more videos and reports of the ACR Convergence 2022. Thank you.